Good morning, good afternoon, everyone. We'll give few seconds rather, for others to join us, and then we'll be kicking off in a very short while. Welcome once again to another edition of Health for the World Grand Round. And we have a very wonderful guest speaker in our midst, and who I'll be introducing us shortly. So let's anticipate. Thank you. Okay, so good morning, good afternoon, everyone. Welcome once again to this edition of the Health for the World Grand Round. So today we are privileged to have in our midst a guest speaker who will be talking to us on esophageal imaging and pathology, and she is Dr. Jessica Zarzour. Dr. Jessica Zarzour is the Vice Chair of Education. She's the Chief of GI Modality and Associate Professor of Abdominal Imaging with she's with the University of Alabama at Birmingham. Currently, she's the Associate Program Director of a Diagnostic Radiology Residency Program. So Dr. Zarzour completed her undergraduate training at Alabama University, followed by her medical school at University of Alabama at Birmingham. She completed a residency training in diagnostic radiology at the same institution, where she served as a chief resident and completed fellowship training in abdominal imaging at the same institution. Dr. Zarzour has served as the program director of diagnostic radiology residency program since 2017. During this time, she has enjoyed mentoring many residents and has been interested and invested in their education. Clinically, Dr. Zarzour practices a full spectrum abdominal imaging, including fluoroscopy, CT, and ultrasound. Her research interests include swallowing disorders, contrast-enhanced ultrasound, diversity and inclusion, and educational initiatives. She's a fellow in the Society of Abdominal Radiology, and she serves on numerous committees with the American College of Radiology. It's our honor today to hear from a resounding scholar and an erudite personality. Thank you so much, Dr. Zarzour, for coming to be with us today. You have the floor.
Thank you so much for having me. I appreciate this invitation, and I'm looking forward to talking about one of my favorite topics, the esophagus, with you. So we will get started. Our objectives here today are to review esophageal anatomy and function. And let's see, I'm going to move that out of the way there. And review common and uncommon esophageal strictures using a case-based format here. So just to start with anatomy review, we'll look at the pharynx here. This is included in all of our fluoroscopic evaluations of the esophagus. And so just reviewing these structures in the lateral image, this is the base of the tongue. The vallecula is here. This is the epiglottis and the piriform sinus. Right here is a laryngeal vestibule that's outlined by barium. And here we can see the vocal cords, and then the trachea, in this case, has barium going inside of it. On the AP view, we see the same structures, the paired vallecula here. This is the epiglottis, the laryngeal vestibule, and then the vocal cords. And this is the trachea again. So the nasopharynx is separated from the oropharynx by the soft palate. And then the oropharynx is separated from the hypopharynx at the level of the hyoid bone. And then the hypopharynx is separated from the cervical esophagus by the cricopharyngeal muscle. And so the hypopharynx is where we're primarily focusing our attention on our barium swallows. The cricopharyngeus, again, is the muscle that separates the hypopharynx from the cervical esophagus. And it's also part of the upper esophageal sphincter. And we'll see some abnormalities with this upper esophageal sphincter, as well as evaluate the lower esophageal sphincter. This muscle should relax normally with swallowing. And if this has incomplete relaxation, then it can lead to problems. So here is an example of a cricopharyngeal muscle that is not relaxing. And this is known as a cricopharyngeal bar or a CP bar. You can see this jet of contrast coursing through this narrowed segment here in the lateral and on the AP images. When we see this contrast jet coming in our barium swallows, it's more indicative of a tight stricture. When this cricopharyngeus doesn't relax appropriately, over time it leads to this outpouching here, superior and posterior to the cricopharyngeus, and can lead to development of a Zinker's diverticulum. So in this case here, we are seeing this tight cricopharyngeus. The upper esophageal sphincter is not relaxing appropriately. And over time, it forms this Pulsion type diverticula that is known as a Zinker's diverticulum that forms superior and posterior to the cricopharyngeus. And on the AP image, it's in the midline. So again, it's superior to the cricopharyngeus. It is a Pulsion type diverticula, and it is midline on the AP images. And this is known as a Zinker's diverticulum. It's the most common type of esophageal diverticulum, more common in the older population, and patients will present with dysphagia and halitosis and symptoms of regurgitated undigested food. Complications can include aspiration pneumonia and malnourishment as a result, and so these are treated with a myotomy here of the cricopharyngeus. Another common diverticulum that we see up in the cervical esophagus is known as a Killian-Jamieson diverticulum. This diverticulum occurs inferior to the cricopharyngeus, and it occurs in the more lateral and anterior positions. So this is less symptomatic than Zinker's diverticulum and is less common and is more often seen incidentally. But again, this is lateral and anterior, whereas that Zinker's diverticulum was posterior and midline. So that's the upper esophageal sphincter. We also need to look at the lower esophageal sphincter and the anatomy of the gastroesophageal junction. So here is a image of the esophagus filled with barium. This X is designating the esophageal vestibule here. The esophageal vestibule is bordered superiorly by the A ring and inferiorly by the B ring. The A ring is a muscular band that will relax and contract normally with esophageal peristalsis. We can also see the A ring here. And again, we can see this esophageal vestibule. The B ring is the demarcation of the gastroesophageal junction. There is a mucosal band at the B ring. It's a thin mucosal band. And again, this is where the gastroesophageal junction is. Over here, we see the B ring here. So this is the level of the hiatus. We can see this pinch as the gastroesophageal junction courses through the diaphragmatic hiatus. And this is important to designate because we don't need to confuse this with a hiatal hernia. This is just an esophageal vestibule, and so it's important to correctly identify where the gastroesophageal junction is. So in this case, we see at the gastroesophageal junction, we see this B ring. So the B ring, again, is a thin mucosal band. And if it becomes tight, it can obstruct passage of a barium tablet. And if it becomes tight enough to be resulting in a patient's dysphagia, then it's known as a Schatzki's ring. So this is another example. We can see this B ring here, or a Schatzki's ring, if it's causing dysphagia. And in this case, it's associated with a hiatal hernia. So here's the diaphragm, and here's the hiatus where the stomach, we have this pinch as it's coursing through the hiatus. In this case, a portion of the stomach has herniated through that diaphragmatic hiatus, and this is known as a sliding type hiatal hernia. So the gastroesophageal junction is above the hiatus, and a portion of the stomach has slipped through the hiatus. So this is a sliding hiatal hernia, and the most common type of hiatal hernia that we see. This is a paraesophageal hiatal hernia. So in this case, the gastroesophageal junction remains at the level of the diaphragmatic hiatus, and other portions of the stomach herniate up through the hiatus. And this is a paraesophageal hiatal hernia. This is a mixed type hiatal hernia. So in this case, here's the diaphragm. Here's the hiatus as the stomach's coursing through it. In this case, the gastroesophageal junction has herniated, as well as other portions of the stomach herniated through. So this is a mixed type hiatal hernia and is also fairly common. In this case, this whole entire stomach has herniated into the chest. So this is known as an intrathoracic stomach. And this stomach has rotated along the organoaxial plane of the stomach and has flipped into the chest. And so here's the esophagus coming down, the gastroesophageal junction here, the gastric fundus, the gastric body, the gastric antrum, and then at the level of the pylorus, it's passing back through the hiatus. So this is an intrathoracic stomach and one of the obviously more larger types of hiatal hernias that we see. So let's look at a normal swallow. It's important to assess peristalsis on our swallowing studies. Normal primary peristalsis will progress in a continuous manner where that primary peristaltic wave empties the esophagus completely. It is show it one more time here because we're going to see some abnormals. But again, this primary peristaltic wave is contracting down and completely emptying the esophagus in one nice wave. So we're going to look at esophageal strictures and how to approach them. We'll look at the location of the strictures, if it's in the upper, mid, or lower portions of the esophagus. And we'll also look at the appearance of the strictures to determine if they are benign or malignant. So we'll start with upper esophageal sphincters. Strictures. In the upper esophagus, the most common type of malignant stricture is a squamous cell carcinoma. And benign types of esophageal strictures in the upper esophagus include congenital strictures, webs, and strictures from bullous skin disorders. So this is a woman who presented with increasing fatigue and dysphagia. In this case here, we're in the cervical esophagus, and we see this thin mucosal web-like narrowing. Again, we can see this jet of contrast coursing through this narrowed portion of the cervical esophagus. So again, when we see this jet of contrast coming through, it lets us know that this is a more significant stricture. So what's the most likely diagnosis here? This is an esophageal web. Esophageal webs occur most commonly in the cervical esophagus. They can be congenital or post-inflammatory, or can occur with Plummer-Vinson syndrome, which is a triad of iron deficiency anemia, glossitis, and esophageal web. So again, here is this esophageal web, and here is this jet of contrast as the barium goes through this narrowed portion of the esophagus. This is another example of an esophageal web. It's normally along the anterior aspect of the cervical esophagus, and it's this thin mucosal band. Again, we can see this jet of contrast coming posterior to it. Okay, so this is another patient who presented for evaluation of dysphagia. So here we are in the cervical esophagus, and we can see this strictured segment extending throughout most of the length of the cervical esophagus. And this more oblique image here, we can see it here extending in this area. So when we're thinking about a differential diagnosis of upper esophageal sphincters, we should think of all of the following except what? Peptic strictures occur lower in the esophagus and are a result of gastroesophageal reflux. These other etiologies, B, C, and D, are all possible options for upper esophageal strictures, I'm sorry. So on physical exam in this patient, we might expect to see blistering skin lesions, and this type of stricture is seen in disorders such as epidermolysis bullosa and pemphigoid. And so these patients will often present, you can examine their skin, and you can see that they may have these blistering skin problems. And these can have these inflammatory strictures, most commonly in the cervical esophagus. These strictures are going to be smoothed and not going to have irregular or shouldered margins. And again, they most often involve the cervical esophagus or upper third of the esophagus. Okay, so this is a younger woman, 16 years old, who presents for evaluation of dysphagia. So again, here we have this narrowed segment in the cervical esophagus on this oblique image, and then here we see it again on the AP image, some narrowing here in the cervical esophagus. The most likely diagnosis here is going to be a congenital stricture. We already looked at a cricopharyngeal bar, so we know it's not that. A pill-induced stricture is going to be more likely occurring at the level of the aortic arch, so a little bit further down in the esophagus. And esophageal webs, again, are these thin mucosal bands that occur in the cervical esophagus. So congenital strictures are fairly rare, but they're going to occur in the younger age population. They may have some other related abnormalities associated with them. Esophageal motility is normally normal in these patients. So it's just this focal stricture in this younger population. Okay, so this is another patient who presented with progressive dysphagia. In this case, is a 58-year-old man. And so here we see, again, this prominent cricopharyngeal bar. Incidentally, we also see a cervical esophageal web here. So again, remember, these are these thin mucosal bands in the anterior portion of the cervical esophagus. But here, this cricopharyngeal bar is fairly prominent. So this patient has a higher likelihood of developing what? This patient has a higher likelihood of developing a Zinker's diverticulum, again, as a result of this Poljan type diverticulum that forms due to this chronic inability of the upper esophageal sphincter to fully relax. The cricopharyngeal muscle, again, makes up the upper esophageal sphincter, is normally contracted at rest, but should relax with swallowing. This will lead to development of a Zinker's diverticulum. Okay, so this patient is another patient who presented with dysphagia and hoarseness. And we can see on these lateral images that this prevertebral soft tissue is thick. So here is the cervical esophagus. Normally it lies right next to the cervical spine. And in this case, there's too much soft tissue here. And so we need to look with a CT neck to see what's happening in this patient. The CT here shows that there is a retropharyngeal abscess, and so that is what was causing the mass effect upon the cervical esophagus, and we can see the abscess here on the AP, the axial image of the CT. So the retropharyngeal space is an important space, as you know, that extends from the skull base to the mediastinum, and it normally contains fat and lymph nodes. Fluid in the retropharyngeal space can be infectious or non-infectious, and when it's infectious, it can be dangerous due to the extension that can occur from abscesses in this area. So it's something that we need to be aware of when we see this kind of diffuse soft tissue thickening when these patients are presenting with dysphagia. This was another patient, similarly, who presented with dysphagia. And again, we can appreciate this really thick soft tissue attenuation here anterior to the cervical spine. On the CT images, we can see that this fluid is less encapsulated, is extending, again, in this retropharyngeal space. In the axial image, we can see it kind of has more of this bow tie configuration. And this is non-infectious retropharyngeal edema. This is bland fluid, and this is often due to altered lymphatic drainage or excess lymph production. And most commonly, we see it in post-radiation patients, but it can also be seen with internal jugular vein thrombosis or retropharyngeal calcific tendinitis. So not all fluid in the retropharyngeal space is infectious, but it's important to exclude that because of the dangers associated with that. Okay, so moving out of the cervical esophagus and into the mid-esophagus, when we think about malignant masses in this area, we think about squamous cell carcinoma, or it can be invasion from an mediastinal mass. Benign reasons for esophageal strictures in the mid-esophagus include pill-induced, radiation-induced, Barrett's esophagus, which is a pre-malignant condition, vascular impressions, as well as eosinophilic esophagitis. So we'll look at some of these examples here in the mid-esophagus. So this is a lady who had a remote history of lung cancer who presented with dysphagia and odynophagia. Here we can see this fairly long segment stricture in the mid-esophagus, extending from about this level down to here. On the AP image, again, we can see extending from here all the way down, and we can see a little bit of contrast accumulating superior to that narrowed segment. So with the history of lung cancer and radiation, this is likely a radiation-induced stricture. Late features of radiation-induced strictures can occur anywhere anytime really, most commonly in 4 to 8 months following radiation therapy, but can definitely occur years later. And they're usually long segment strictures, and they're smooth, typically without ulceration. And again, it's all about the clinical history here. If someone's had a history of radiation, then our suspicion for radiation stricture would be higher. This is another patient who had progressive dysphagia. It actually occurred during her radiation therapy. So we can see here is the lung mass here. This is her small cell lung cancer. And over here on our esophagram images, we can see the segment of smooth narrowing in the mid-esophagus, right where she was receiving her radiation therapy. So again, we have a radiation-induced stricture, but this time occurring in a more acute time period. So early changes when we have radiation-induced esophagitis is we can see more of these superficial irregularities in the mucosa. And there's often also going to be dysmotility in the segment that has been irradiated. Okay, the next patient here is a 16-year-old man who presented for evaluation of dysphagia and chronic cough. So here we see a posterior impression upon the mid-esophagus. And so we start thinking about our vascular compressions. So the thing that is not in the differential for a posterior compression of the esophagus is a pulmonary sling. In a pulmonary sling, there will be an anterior compression on the esophagus. In these other etiologies here, we're going to have a posterior impression. So we'll look at each of these just quickly. So again, these are causes of posterior esophageal compression. We'll see this in a double aortic arch as the arch wraps around posterior to the esophagus. We see it in the setting of an aberrant right subclavian artery that is coursing around posterior to the esophagus. And we can also see it in the setting of a right arch with an aberrant left subclavian artery that's coursing posterior to the esophagus. So all three of these vascular anomalies can cause this posterior compression upon the mid-esophagus. An anterior compression is normally caused by a pulmonary artery sling. This is when the left pulmonary artery is originating from the right pulmonary artery and courses between the esophagus and the trachea. And it can also compress the right main stem bronchus. But what we see here is this anterior compression along the mid-esophagus. Okay, this is another patient who is a 55-year-old man. He presented with gastroesophageal reflux and hiatal hernia and was having dysphagia. So here we see this kind of smooth compression along the upper thoracic esophagus. And so the best next step in management here is going to be chest CTA. This looks like it is arising from next to the esophagus and causing this mass effect. And so these other things are going to be in the differential. An esophageal leiomyoma is going to have these smooth margins. Aortic ectasia or aneurysm can have this smooth compression or a vascular anomaly. This is not what adenocarcinoma looks like. I will show you some examples of that, but that is typically a malignant looking stricture within the esophagus itself, not something outside of the esophagus resulting in mass effect upon the esophagus. So in this case, we see that, oh goodness, sorry. We see that there is a right-sided aortic arch with an aberrant left subclavian artery with aneurysmal dilation of Comarell's diverticulum, which is causing mass effect on the trachea as well as the esophagus. And so that was what was causing this mass effect upon the patient's esophagus here. Okay, so this is another patient who has a history of heartburn and presented for evaluation of dysphagia. So in this case, we have a stricture in the mid-esophagus. This patient has findings of gastroesophageal reflux disease. So here's the level of the hiatus. We can see the diaphragm. The hiatus here is very widened, and we can see the gastric folds extending up and to above the hiatus. So there's a hiatal hernia here. Here we have this stricture in the mid-esophagus, and on the double contrast images here, we can again appreciate this stricture. So this is Barrett's esophagus, And this is a segment of columnar metaplasia in the distal esophagus that is due to chronic gastroesophageal reflux. These strictures can occur anywhere along the esophagus, most commonly in the mid-esophagus, but can be as high as the level of the aortic arch. So it is a pre-malignant condition and can lead to increased risk of adenocarcinoma. So patients who have been identified with Barrett's undergo endoscopic surveillance. Okay, this is a 43-year-old man who has a history of alcohol and tobacco and drug use and presented for weight loss and dysphagia. Here we see this very tight stricture in the mid esophagus. Here we can see the lateral images, and then on the AP. Here the stricture has these shouldered margins. We can see some ulceration within it, lots of mucosal irregularity, and again, these sharp marginated segments as we go from abnormal to normal esophagus. So here, this is a malignant stricture, and in the mid-esophagus, it's more common going to be a squamous cell carcinoma, although adenocarcinoma would be within the differential. Risk factors for squamous cell carcinoma include alcohol, tobacco, are the most common risk factors. These may have direct mediastinal extension and early lymphovascular spread, and most commonly, again, they're going to be in the upper or mid-esophagus. This patient has complaints of dysphagia. Again, we can kind of see this smooth compression along the mid and distal esophagus. Again, this is looking like it is extrinsic to the esophagus, not within the esophagus. On this lateral image, we can see that this compression is on the posterior portion of the esophagus, producing some mass effect. And so this, we got a CT to evaluate this further. And here we can see this fluid attenuation collection compressing the esophagus towards the left. And this is a duplication cyst. Esophageal duplication cysts can occur anywhere along the esophagus. More commonly in the GI tract, they arise from the distal ileum and duodenum. They are typically well-defined and are going to be cystic. They are typically less than 5 centimeters. Okay, so moving out of the mid-esophagus and into the distal esophagus, we will again consider malignant and benign strictures. The most common malignant stricture in the distal esophagus is adenocarcinoma, and the most common benign stricture in the distal esophagus are peptic strictures and achalasia type narrowings. Okay, so this is a 34-year-old man who had a prolonged hospitalization following trauma who presented with dysphagia. So in this setting of prolonged hospitalization, patients may have a nasogastric tube in for a long time. When a nasogastric tube is in the esophagus coursing through the gastroesophageal junction, it sets the patient up for this chronic gastroesophageal reflux. So in this patient, we see this long segment stricture involving the entire distal esophagus. And this is related to that chronic reflux from nasogastric tube being placed. When these tubes are in place, it is important for them to be on acid-reducing medication to prevent this post-inflammatory stricture. Here is another patient who had a prolonged nasogastric tube. This is a barium tablet. You can barely see there, hopefully. And again, these narrowings are smooth and typically long segment and involving the distal esophagus as a result of that chronic gastroesophageal reflux when a nasogastric tube has been in place. This is a 60-year-old man who had progressive dysphagia and weight loss. Here we have this very irregular appearing stricture with shouldered margins, a large ulceration here, lots of mucosal irregularity. And so in the distal esophagus, this malignant stricture is most likely due to adenocarcinoma. Adenocarcinoma develops from columnar metaplasia of the distal esophagus and can occur from longstanding gastroesophageal reflux. It's the most common malignant tumor of the esophagus in the United States. And on barium swallows, we can't distinguish it from squamous cell carcinomas, but the distal esophageal location suggests adenocarcinoma. But ultimately, this will require endoscopy and biopsy for confirmation. This is another example of an esophageal adenocarcinoma. Sometimes these can occur very low at the gastroesophageal junction. So here we can just see this really shouldered margin at the gastroesophageal junction. And so it's important as we're examining these patients to really look carefully at the gastroesophageal junction, making sure we're not excluding that from our field of view. In this image, it shows this is the barium tablet that became obstructed at that level. And this is the corresponding CT image where we can see this mass extending into the gastric cardia. This is a man who has a history of scleroderma who presented with complaints of dysphagia. So the esophagus is often affected by scleroderma and has several associations. With scleroderma, these patients have continuous gastroesophageal reflux, and so they are set up for reflux esophagitis and peptic strictures and Barrett's esophagus. They're also at an increased risk of adenocarcinoma, and there's no association with scleroderma and cervical esophageal webs. So scleroderma is characterized by absence of primary peristalsis within the thoracic esophagus, as well as a patchless lower esophageal sphincter. So there's no primary peristalsis, and the lower esophageal sphincter is just wide open. It isn't contracting the way it should. And so these patients have this continuous gastroesophageal reflux and can set them up for complications such as reflux esophagitis, peptic strictures, Barrett's esophagus, and adenocarcinoma. These are other images from a patient who has scleroderma, and we can see that the lower esophageal sphincter is wide open here. There is no protection from gastroesophageal reflux because the lower esophageal sphincter is just open, is patulous. With scleroderma, this is a video showing as they swallow, there's no primary peristalsis once we get into the thoracic esophagus. The rest of the esophagus is just patulous, is not contracting. The lower esophageal sphincter is just open, and these patients will sometimes also present when they are standing and swallowing. We can see a column of barium in their esophagus due to this impaired mobility. And so again, here's a lower esophageal sphincter. It's just wide open and there's no primary peristalsis. So lots of stasis here in this esophagus. Okay, this is a 63-year-old man who has a history of gastroesophageal reflux and presented for evaluation of dysphagia. So here, this is the hiatus here. We can see the stomach coursing through it. So this is a sliding type hiatal hernia. We can see the gastric folds coming up to the level of the gastroesophageal junction. At the gastroesophageal junction, we see this narrowing. We see some sacculations here and some scarring. And so this is a common appearance of a peptic stricture. And peptic strictures occur due to scarring from chronic esophagitis. And they typically have smooth, tapered margins with concentric narrowing. We can see, again, some of these sacculations here and some of the transverse folds extending due to the scarring. Most of these will have an associated hiatal hernia. This is another example of a peptic stricture. So here is the hiatal hernia. This is the hiatus. So we have a sliding hiatal hernia here. And this is another peptic stricture as a result from chronic scarring from gastroesophageal reflux. Some associations that we see with gastroesophageal reflux and peptic strictures, we can see here. So here we have this smooth narrowing in the distal esophagus. We can see it over on this side here. Here there is a hiatal hernia, so we can see the gastric folds extending up to this level. This is the level of the gastroesophageal junction. Here we can see these tiny little outpouchings of barium occurring throughout this strictured segment. Over on the single contrast images, again, we can see these outpouchings of contrast. So these are known as intramural pseudodiverticula, and they occur in the setting of chronic inflammation. So they're not always associated with gastroesophageal reflux, but the association is just with any type of chronic inflammation. And the most common type of inflammation we see in the esophagus is gastroesophageal reflux. So it is something that we often see. And just to show you an example too of other associations with gastroesophageal reflux, this is all the same patient. This is a double contrast image of the esophagus. And then these next two images occurred after the patient belched. And we see these thin transverse folds extending across the esophagus. And this is what is known as feline esophagus. And it's really insignificant other than just to know what it is so that you don't get it confused with something else that is more significant. But it occurs when there is gastroesophageal reflux. This is a reaction that the esophagus will have sometimes to that gastroesophageal reflux, but it's transient. So that's the important thing here. So 1 minute it looks normal. The next minute you can see these transverse folds, feline esophagus, and then the next minute is back to normal again. So it's just occurring during those episodes of gastroesophageal reflux. Okay, this is a man who presented with severe progressive dysphagia for both solids and liquids. So here we see that the esophagus is dilated and there is barium that is accumulating within the esophagus, and we have this column of barium. The whole esophagus, though, is filled with fluid and food particulate up until about this level here. I think it's hard to see on these images, but this is a column of barium, a column of food and liquid, and then we have barium layering down here. So this is achalasia. Achalasia is characterized by failure of relaxation of the lower esophageal sphincter and absent primary peristalsis. So with achalasia, we can see on CT a dilated and fluid-filled esophagus. With endoscopy, we can see this dilated esophagus, and it has retained barium in it, and it has this puckering at the GE junction. So achalasia means failure to relax. And patients present with dysphagia, regurgitation, heartburn, chest pain. This was first diagnosed radiographically with the observation that the esophagus is dilated in achalasia. There is absent peristalsis. So again, like scleroderma, there's no primary peristalsis. But in contrast to scleroderma, the lower esophageal sphincter in achalasia is not relaxing. So there's incomplete lower esophageal sphincter relaxation. With manometry, we also see the absent peristalsis and the incomplete lower esophageal relaxation. With high resolution manometry, these achalasia is being characterized into different subtypes to quantify the lower esophageal sphincter relaxation and the peristaltic function. So type 1 achalasia is what we typically see, which is the classic dilated esophagus with bird's beak appearance at the gastroesophageal junction. We have 100% failed peristalsis, and with manometry, we see absolutely zero peristalsis happening as the patient swallows. With type 2 achalasia, the esophagus is less dilated, and we may see some tertiary contractions. As there are tertiary contractions, the upper esophageal sphincter and the lower esophageal sphincter are both contracted. And so we have this pan-esophageal pressurization. And that's what we see with high-resolution manometry. With type 3 achalasia, again, as with all types of achalasia, there's going to be no primary peristalsis, and there's going to be failure of the lower esophageal sphincter to relax. But with type 3, we're going to see some tertiary contractions that are pretty high amplitude contractions. And so this is known as spastic achalasia or type 3 achalasia. And these subtypes are important to help direct treatment for these patients. So this is a 75-year-old who presented with a history of achalasia. And so this can be a dangerous situation when someone is presenting with a diagnosis rather than with symptoms. And so they're coming in saying they have achalasia. So as radiologists, it can make us kind of think about, oh, well, this person has achalasia. But in this case, the esophagus isn't that dilated. There certainly is, the esophagus is not emptying normally. We have a fluid level here in the upper esophagus, and we timed these images at 1, 2, and 5 minutes the way that we characterize achalasia. But in this case, this was an acute onset of achalasia, and we can see that we don't have the classic bird's beak appearance like we had back here. This is this classic bird's beak appearance in achalasia. And in this case, there is kind of a long segment of narrowing here. And so this is what is known as pseudoachalasia. So it's an achalasia-like pattern of the esophagus, but it's caused by narrowing of the distal esophagus from a cause other than achalasia. And most commonly, this is a malignant stricture. The history in these patients is often shorter. The symptoms of dysphagia are shorter, and it typically occurs more commonly in older patients. And so it's just a caution not to get too, I guess, sidetracked by the indication given, and to be thinking of all possible causes, particularly in the older population when they're having impaired esophageal emptying. So this was a 42-year-old who had progressive dysphagia. Again, so we talked about the anatomy of the gastroesophageal junction before, and here in this case, this B ring has become tight enough to obstruct passage of our barium tablet and causes patients dysphagia. So in this case, we call this a Schatzki's ring. Okay, in the last segment of the esophagus evaluation is just a variable or diffuse esophageal narrowing or abnormalities. And so we'll look at a few last cases. So this was a 30-year-old man who had no significant past medical history and presented with dysphagia and odynophagia. So here throughout the entire esophagus, we have these diffuse thickening of the esophageal folds. We have extensive mucosal irregularity, and this is what Candida looks like. It is most commonly characterized by odynophagia, and is the most common infectious cause of esophagitis. It is more commonly occurs in the setting of immunocompromised patients, but can also occur in the setting of stasis, such as patients who have achalasia or scleroderma. Many of these patients will have oral candida, so it's important to do a physical exam and look in their mouth and see if you see any signs of candida in their mouth. This patient, this was the initial presentation, he was subsequently discovered to have AIDS. The esophagram will show these plaque-like lesions that usually line up longitudinally and are separated by segments of normal mucosa. In this case, we don't see much normal mucosa at all, but it has this shaggy appearance, and it's caused by this coalescence of these pseudomembranes and plaques with trapping of barium in between them. This is a 57-year-old man who presented with dysphagia and chest pain. So in this case, I'm going to show you a video here because it illustrates it better, but you can see these tight, high amplitude tertiary contractions that are occurring throughout the esophagus. We can see how tight these strictures, I'm sorry, they're not strictures, they're contractions, how tight these contractions are occurring, and they're impairing emptying. So this is distal esophageal spasm, and this can involve the entire thoracic esophagus. These patients will present with dysphagia as well as chest pain commonly. Here is another example of someone with distal esophageal spasm. As they swallow, we can see these tight, high amplitude tertiary contractions that are impairing esophageal emptying. It's been described as a corkscrew type appearance. But again, as these contractions are occurring, barium is being propelled superiorly into the more superior portion of the esophagus. This is a 17-year-old man who had a history of dysphagia for several years. So here in the upper esophagus, we have this kind of area of narrowing that is subtle, but we can certainly see these rings in this thoracic esophagus. When we gave the barium tablet, it did become obstructed at this level. And so this is a picture of eosinophilic esophagitis. Eosinophilic esophagitis is associated with food allergies. These most commonly occurs in adult males. And again, they're going to have a history of a food allergy. And this diagnosis is confirmed with endoscopy, where there are greater than 20 eosinophils per high power field. And it leads to chronic inflammation and eosinophilic infiltration of the submucosa. And the most classic appearance that we see is this ringed esophagus, but it most commonly occurs in the, mid esophagus, but can truly occur anywhere in the esophagus. And so just something to keep in mind if a patient has a history of allergies and kind of long history of dysphagia. The treatment for this is steroids. This patient had a history of lye ingestion. These are often really sad cases. The entire esophagus is strictured. And in addition to strictures, these patients also have an increased risk of all sorts of things, such as cancer, perforation, and fistulas. It classically presents with diffuse severe narrowing of the entire esophagus, and it can typically develop 1 to 3 months following ingestion and has an increased risk of carcinoma for many years. So just to recap, looking at benign strictures, looking at the location. So in the lower esophagus, the most common etiologies for a benign stricture are peptic strictures as a result of gastroesophageal reflux, achalasia, a prolonged nasogastric tube, and scleroderma leading to peptic strictures. In the mid-esophagus, the most common types of strictures are Barrett's esophagus, radiation-induced strictures, pill-induced strictures, and vascular rings. In the upper esophagus, the most common strictures we see are congenital strictures, cervical esophageal webs, and blistering skin disorders. And then with variable or diffuse type of involvement, we can think about infectious and inflammatory etiologies, caustic ingestions, and eosinophilic esophagitis. With malignant strictures in the lower esophagus, we need to think about adenocarcinoma. In the mid-esophagus, Barrett's esophagus, again, is a pre-malignant condition, and we can see squamous cell carcinoma and adenocarcinoma in the mid-esophagus. The upper esophagus is more typical of squamous cell carcinoma, and then lymphoma and metastatic lesions can, of course, occur anywhere throughout the esophagus. As we think about benign versus malignant strictures, with benign strictures, the margins are going to be smooth, and the mucosa is normally going to be normal unless there's some type of chronic inflammation, such as peptic strictures. With malignant strictures, the margins are going to be more irregular. There's going to be these abrupt shouldered edges associated with the malignant stricture. The mucosa is going to be spiculated and irregular, often going to have associated ulcerations, particularly in the setting of adenocarcinoma. So that is all I have here. These are references, and I will pause for questions. And let's see, I'm going to stop sharing my screen.
Okay. Thank you very much, Dr. Zarzour, for this wonderful lecture. Personally, I was glued to my screen because there were a lot to learn. We are really grateful from all of us at Health for the World. We are grateful. Thank you so much for coming around this morning
Thank you so
educate
much.
us. Okay, so this is time for question and answer. Currently there is no question on the chat box or in the Q&A box. So I believe our attendees really learned a lot also because they were quite active on the chat box. So a lot of them were answering questions as the lecture were going on. So thank you very much. Okay, there's a question now on the Q&A box. Let me see. Okay, so this is more of a general question. He said, what do you think about the endoscopy? I don't know. Okay, that's a little bit more general, but there's a second question here. Thank you for a nice presentation. How much is risk factor of untreated achalasia expose patients to a carcinoma or cancer? So you're just trying to ask the risk factor for a patient with achalasia to coming down with cancer later on. So please.
I think there is an associated risk. I'm not sure exactly what that risk is as far as a number. I think it is due to the, the chronic stasis there in the esophagus leading to chronic inflammation. And so there is an associated risk there. I don't know exact number, but that is one of the reasons why people will opt for treatment of this, is in addition to just symptomatic relief of being able to swallow normally.
Okay. Thank you very much for that. So another question is trying to ask the difference, maybe just for you to differentiate between the peptic stricture and the Saski ring.
Yeah.
Maybe it was a little bit confusing for this person. So
Sure. So yeah, the Schottky's ring is just going to be that thin mucosal band. It's just a nice little ring at the gastroesophageal junction. It's very thin, and it is at that B ring there at the gastroesophageal junction. With the peptic stricture, it can really occur anywhere in the distal esophagus. It certainly is more common at the gastroesophageal junction, but definitely in the distal esophagus. And those peptic strictures are also going to be smooth, but they're not going to be ring-like, like a Schottky's ring. They're going to just be more like a smooth tapered stricture, maybe extending 1 centimeter or 2 centimeters in length, whereas that Schottky's ring is really just 1 or 2 millimeters.
Okay, yeah, thank you very much. Okay, the question on endoscopy, he was trying to ask, like, if there is any advantage of endoscopy to radiologic investigations when investigating the pathologies of the esophagus, if
Yeah.
there is any.
Yeah,
Oh,
that's a
sorry.
good question. I think normally we use barium swallows as kind of first line screening. So if a patient is having a history of dysphagia, they will often start with us in radiology for a barium swallow, and then if we detect an abnormality, would move on to endoscopy. So there could certainly be other practice patterns out there, and it could be that some practices might start with endoscopy, just depending on resources and things like that. But if we typically start in radiology and then send them to endoscopy if needed, but it could go either way.
Okay. Thank you very much. Okay, so there's another question. Just is asking on how you can easily differentiate between an esophageal vestibule from a sliding hiatus hernia.
Yeah, that's good. It's an important distinction. The best way is to identify the gastroesophageal junction. And that's best identified by following to see where the gastric folds terminate. And if you can identify that mucosal bearing that occurs there at the gastroesophageal junction, sometimes you can only just see like a subtle little notch, that's like a millimeter indention into the gastroesophageal junction. And it's best to kind of follow where those gastric folds are terminating. Is also while you are doing the fluoroscopy, the esophageal vestibule hopefully will become apparent, because along the superior margin of the vestibule is that A-ring that is going to be opening and closing. And so as you're watching, when you're doing these fluoroscopic exams, hopefully that also will help distinguish those. The other thing I have found that's helpful when you're looking for the gastroesophageal junction is when the patient's laying down and swallowing barium. If you have them take a deep breath, it's going to cause their diaphragm to be pushed inferiorly, and it's going to really accentuate any hiatal hernia and can also oftentimes accentuate the gastroesophageal junction. So that's just another little tip there if you're struggling with finding exactly where the gastroesophageal junction is.
Okay, thank you very much. There is can I ask another question?
Yeah.
Or okay, so this is actually a question on whether there have been a case, whether you've seen a case of a patient that's developed a cancer while eating very hot food or maybe drinking very hot tea regularly, maybe in the course of your practice, if you've seen such case or if it exists.
I'm not aware of that. I don't know. I
Okay.
mean, it could have been that I've seen it and wasn't aware of it, but I have not been aware of a patient who's developed cancer from hot foods or drinks.
Okay. Thank you very much. Okay, so the last question is, can a traction diverticulum perforate?
Yes, it can. And yes, I guess any type of diverticulum could potentially perforate. And on barium swallows, we would see that as extravasation of barium into the space where the perforation is. Or CT, obviously, we'd probably need to get a CT to see that more clearly. But yeah, for sure.
Okay, okay, I think, okay, sorry, there's a last question. Can we take that and that will be the last?
Okay.
Okay, so is there a diverticular of oropharynx that occur because of cranial nerve palsy, like a brainstem tumor?
I'm not aware of that.
Okay.
Yeah, no, I'm not sure about that. I did see a question about how does a pill cause a stricture? And
Yeah, I just said that now.
Yeah. So that one, certain types of pills, certain types of antibiotics, certain types of like bisphosphonates, if they get stuck at the level of the aortic arch or other places in the esophagus, and they get stuck there for some time, they can cause some inflammatory changes in the esophagus and can be strictured down. And so that's what that pill esophagitis is referring to. That was a good question.
Okay. Thank you very much, Dr. Zarzour, for answering all our questions. And we're really glad to have you with us. And I think we have to actually let you go too, so you can attend to other aspects of your day. Thank you so much.
Thank
I
you
wish
so
you
much
a
for
very
having me.
wonderful